So this session, we're going to have a slightly different format from the ones that we've been doing before because it's the first time that we're going to have slides. But we're really, really excited about sharing some of these posters and some of these lectures and abstracts that we found that were really interesting to for all of you to learn about. Um, in this case, like I didn't go to ASCO this year, so I'll let John and Jason be the experts of here today. And if any of you have attended ASCO, like please also share anything that you found and like stop us and be part of this conversation. But I always find that when I don't go, it's just so hard to keep up with all of the conversations that happen, all of the trends, all of the presentations. And so we thought this would be a great way of getting everyone up to speed. Quick intro before we get started. My name is Mariana Arnaud. I am the CEO and co-founder of The After Cancer, and we're running this session today with John and Jason. So I'll let you guys introduce yourself. John.
Sure. John Hennessy. My current gig is I'm an associate principal at Pear Sciences. We work on making sure patients get access to the medicines they need. My background before that is as an oncology practice manager, managing hospital service lines, and focusing on access for self-funded employers, trying to make sure their patients get oncology benefits. I'm a former ACCC volunteer. I'm an ASCO volunteer, and I'm serve on the board of the Young Survival Coalition, and I'm a board certified patient advocate.
Thank you. Jason, over to you.
Hi everyone, I'm Jason Binder. I'm the founder and CEO of Ember Health. At Ember, we build companions to help families navigate through cancer, to ask basic questions and know what you don't know. This comes out of my experience being a caregiver to my wife, who was diagnosed with glioblastoma in February 2022 and lived for 45 months before passing away last November. I also have 25 years in pharma doing data and analytics transformations in oncology drug development, previously at AstraZeneca, Genentech, and Merck. And I realized how hard it was for us to know what was going on and know what questions to ask. And I've got supposedly all this experience. I just thought about those that don't have the same background. How are they really even navigating this? Know what questions to ask, especially in a context where there's so much time pressure. It's hard to make good choices. So what can we do to use technology to aid in that? So thank you for having me.
Thank you, Jason. And technology is actually going to be one of the topics that we're going to be presenting a few posters and a few events. Watch this space. That's going to be the last topic that we're sharing today. Just before we get started, I cannot do this session without presenting the after cancer. The after cancer, we say that treating cancer is just the beginning. We work with health systems to enable them to provide clinical grade survivorship care without extra cost, without extra burden. And so the results that we see is like better patient outcomes, better quality of life, reducing overall costs of how much survivorship drives, and also being able to capture data that is required for reporting, for quality accreditations. We help with COC and others. So if you're interested in learning more, feel free to reach out after this session. So let's go for the reason why you came here, because I know you didn't come here to hear about the after cancer. We selected 5 different topics on based on all of the abstracts that we could find. I'll caveat I didn't read all of them, but I looked at what it was in survivorship and what were the like most interesting topics. I would love to, yeah, meet one individual who read all of them. That must be awesome. John is saying no,
No,
not
you don't want to meet
possible.
that person.
I hope that person is not on the call. If by any chance we talk about a study that it's on your field of work or that you were part of, interrupt us, like be part of this conversation because we can only learn from you too. So let's start with weight management. I have to say, this is something that comes up so much in survivorship with our patients, in particular, patients with hormonal cancers, breast cancer. so many questions about nutrition, how to lose weight, how to exercise, what can I do, diets, GLP-1s, who haven't heard of them, right? Like they're everywhere. I think there's a really, really big buzz. We're seeing patients taking them too. And so we finally have a little bit of research to back it up. So this first abstract was about barriers of integrating obesity management into cancer survivorship care. I think this was known that these barriers existed. And basically, the recommendation are nutrition, movement, medication pathways, easier to access for the oncology team to be able to refer their patients to. John, Jason, any comments on this one?
I mean, I'd start out by saying that if you were at the poster sessions Saturday, Sunday, or Monday, you would be it would not surprise you that some of the lifestyle management opportunities have as much influence on quality of survivorship and length of survivorship as a lot of the medicines that we have. And that was certainly the takeaway for me. The other challenge I think we face in this area is that our healthcare payment system is it's organized around, sort of medical therapies and non-medical therapies, and it matters from a coverage standpoint, and some of that has to do with our tax system. It's no surprise that something that eats up 19-20% of our GDP is a little messier than we would hope it would be. That said, my experience from running a practice is that oncologists are good at oncology, but not necessarily all the other stuff that matters to oncology patients. I typically we see a ratio of if I go to a practice for every oncologist, there might be 9 or 10 other employees doing all sorts of other things. The practice I ran, we had begun integrating some of this stuff into care, but I think this study and some of the other things we saw highlight that you can't just put someone who understands obesity management into an oncology practice and hope some miracle is going to occur. You really have to create workflows and referral paradigms and feedback mechanisms to not only start these programs but to grow them as well. And the sadly, when budgets get tight, these are the first things that disappear as well. So I was excited to see all the evidence here. I think there was a poster, I don't know if we'll have it on here, but it said that in 2022 to 2024, about 6.9% of the posters at ASCO's annual meeting were about survivorship. So to see this discussed in the same setting as these amazing drug discoveries alone is a good start. But I think these ideas that, sort of shining a light on these gaps is really important to understand. You can't just throw a program out there. You actually have to integrate it into the care paradigm.
Yeah. And like what you mentioned about the challenging, which is this is not a one-off visit that the patient is going to have with with the doctor. This is continuum care, which is something that also we see a lot of practices struggle with because that's not why hospitals were created. It's for acute care, not continuum of care. So yeah, really interesting. I did feel that this year there was even more on lifestyle than last year, just as a gut feeling. I don't have the numbers, but when I looked at the posters, there was definitely more. We have this second poster, and John, this was something that you shared with us about GLP-1s, which is part of the solution of what we were seeing before, but much more complicated to implement than might seem. Do you want to share your thoughts on this one?
It just, I want to say briefly, but it's not a brief topic.
Yeah.
This was also something that I think we'll see exploding next year. We saw, I think I looked in maybe 40, 50 different posters on this or abstracts focused on really three areas. One, incidence. Will GLP-1s, because of what their health effects, reduce the incidence of cancer, particularly cancers that may be driven by obesity or diabetes or other sort of cardiometabolic conditions? The second set, we're sort of asking the question is, will GLP-1s impact the treatment paradigm? So are they going to be part of a regimen or a cocktail that will be more effective at treating the cancer. And the last part is GLP-1s and their effect on survivors. And I think this is really important. You've mentioned that weight and lifestyle are an issue in survivorship. We don't really know how GLP-1s will interact with that survivorship journey. And so to me, they're all sort of urgent to understand this, but this is the most urgent because I think people have readily access to this. And if
Yeah.
you go to one of the telemedicine programs and you seek these products out and you don't happen to mention you're a cancer survivor, we don't know what's going to happen here. So I'm excited for the opportunity to study this so that we can give patients and caregivers good advice about this. Jason, I'm wondering if that's, consistent with what you were thinking about this.
Well, I mean, I think you see GLPs just so prominent across the entire spectrum. This was bound to come up. I think it was on the previous slide you talked about, patients talking about fatigue and talking about other types of nutrition. Um, with Ember, we have folks asking that question all the time about, supplements and herbs and diet. Those are common things to be talked about. There's not a great resource around interactions, and I don't know exactly how you define survivorship in the after cancer if people are still going to be on treatment of some sort
Yeah.
or some sort of a symptomatic treatments. So like drug to drug interactions are unclear at this time, I think, with some of these peptides. So, there's definitely the benefit of being healthy and the benefit of like exercise and movement on survivorship. But I think it'll be interesting to see where we start to see the interactions of GLP-1s and the pathways of some of these treatments, if there's any types of interesting outcomes that come because of doing both of those at the same time, potentially.
Yeah.
It may be worth noting that a lot of these are going to wind up being observational studies. So it will be hard to separate out, all the things that are all the moving parts. We're unlikely to see randomized controlled clinical trials here in survivorship, if only because these are effectively retail drugs. They're available if you have not a lot of cash, but some cash. You can access these medicines, and for better or worse, some of us, tell our doctors everything, and some of us don't tell our doctors everything, especially if they're doctor on my phone.
Yeah. We have here a comment on the chat. Kai Andrews is sharing this is the question I get asked the most in my breast practice. I'll share a resource afterwards about GLP-1s. We had an interesting conversation with two physicians, Dr. Billy Dordan and Dr. Mindy Goldman, about the potential role of GLP-1s and the risks of it, and when it should be used or not. So I'll share those resources afterwards so you can have a look at it. But yeah, still a lot to be researched in this space, but definitely seeing an adoption from a commercial standpoint. Like it's everywhere. Um, so the second topic we found a few interesting abstracts was around pain, and in particular, like long-term pain, long-term symptom management. So let's look at this one. Again, this is a study that observed the recovery of patients with neuropathy. Again, this is one of the main side effects that we see from patients in our clinic. I don't think this says anything surprising, but it's interesting to actually be able to put some stats on here. At least that's what I felt from a clinical perspective. So we know that within this group of patients that had different types of cancer, lung, breast, ovarian, about 50% improved, a third remained stable, and there was a small subset that got worse over time. Neuropathy is a tricky symptom because there's not a lot of ways of actually treating it, even like medically. Lifestyle can help, but it's not said that it will 100% eliminate it. So, Jason or John, any comments on this one?
Yeah, I guess what I would start with is I think on the when I put on my practice management hat and hospital leadership hat, um, I think the notion that this is a big deal for patients is really important.
Yeah.
And too often, in when you're running a practice or you're in practice, this is a common side effect. So you think, oh yeah, people have neuropathy, and he said when my doctor said that, I would say, well, would you like to try it? While we may see it commonly, it is uncommon for the individual patient.
Yeah.
I think one of the challenges we often see in practice is this balancing act of I want to treat the cancer and sort of titrate it as much as I can and tolerate as many side effects as possible. But I think for a lot of folks, they expect the side effects to wane, whether that's realistic or not. That's an expectation. And so really, hopefully empowering people to say, hey, this is enough. The other piece of that, I think, in Jason, you've mentioned this too. When you think of frailty, when you think of, the three F's, fatigue, falls, and fractures, this is a contributing element to that. So I think heightened awareness, not just from the clinical side, from the patient and caregiver side, to say, hey, when these symptoms start coming up, start thinking about this balancing act that's coming along. I mean, the good news is taxanes work. The bad news is that they bring these side effects. And that's not just taxanes. I mean, virtually everything we do has this trade-off of effect and side effects. And the newest things we're doing, when we think about Trodelvy, which is a very new drug and very exciting, substantial side effect burden, CAR Ts, bispecifics. So this is something I think we just have to get better at, which is this balancing act and not this, white line fever about we're just going to do everything we can to control the disease. We have to build lifestyle and build what's important into that as well.
Yeah, I know. Well, my wife Tracy didn't have a taxane-based chemotherapy. Just with Teminar, she experienced, left side tingleness and lack of feeling on left arm and leg for the entire experience. And that definitely posed an issue to her. But might be interesting to know, and I don't know off the top of my head for breast, ovarian, and lung, like where taxane fits in the lines of therapy. Because I think it's maybe down the line after you think about some of the more precision medicines, but I think it's a good conversation to have as you're progressing through that. I don't know if there's an expert in the audience who knows where taxane fits in that, or if John knows.
I think in ovarian cancer, it's still kind of in first line.
Yeah.
It's we used to say in ovarian cancer, you can have carbotaxol, or carbotaxol. As
Gotcha.
we get more targeted therapies, we're getting away from that. But I think it's worth noting that just because something's targeted doesn't mean there aren't adverse events. Maybe not neuropathy, but there are other challenges. There are plenty of targeted therapies with some rashes that are really challenging for patients. And that's where, as clinicians, we have to be good listeners to figure out how do you dose reduce, how do you dose delay, how do you balance. I want to treat the cancer, but I want to make the quality of life acceptable as well.
Yeah. And one note I would put here in particular for post-treatment, this is something that lingers with patients. So here we're talking about th over 3 years. And we oftentimes see that like patients know that it can happen and they'll like live with it and they'll struggle and it's going to be like debilitating for them, but they'll still continue their lives. And they're only going to seek treatment when it's something really, really, really bad. And this is the type of side effect that with more supervision on what's normal, what's not normal, and like more education on the patient perspective too, we can avoid some situations where people are having to get surgery or things like that. This is currently something we're experiencing with some of our ovarian patients who had neuropathy for months, years, didn't do anything about it, and now suddenly cannot like move a finger. So it's yeah, definitely a big one.
Brutal.
This one was shared also by you, John.
Mhm.
Um,
I mean, we
Pain.
know that I'm on the board of the Young Survival Coalition, been on the board for 15 years. It's hard to keep track anymore.
Mm.
Um, but one of the big issues is we know aromatase inhibitors improve survivorship. We know that they come with all sorts of adverse events that lead to not just dose delay, but discontinuation. And so it's really incumbent upon us to figure out how to help people, acknowledge that there are side effects, but how can we make them manageable so that people can stay on the medicine and really get the most out of the product. And this is, I mean, it's good news in the United States, but particularly around the globe, aromatase inhibitors are very inexpensive. So if we want to think about the global impact of something like this, but basically, a simple approach here of saying a multidisciplinary pain program, which is not just trying to say, oh, don't worry about it, but what can we do to give you tools to adapt to the pain, manage it, and make and make your life as good as possible as we try to extend it as long as possible. And we know
Yeah.
that multidisciplinary care matters a lot in oncology. So this is, I don't know if this is especially news, but it's nice to highlight it and show that it does make a difference.
Yeah. And I love the fact that one of the disciplines they're using is CBT based workshop. So that's bringing a therapist, talking about cognitive behavioral therapies and tools that patients can bring home to manage when they're having a flare up or like not feeling as well. Um, for aromatase inhibitors, something that we're noticing is also like a fear factor amongst patients, and we've definitely seen patients who said, I'm not going to do it without even
Mhm.
trying. Dr. Billy Dorton, my co-founder, always talks about these treatments on there's three buckets of people. You should always try to see where do you fit. You're either going to be totally fine, you're either going to have some side effects that are manageable, or you're going to have some side effects that are just like not, you're not going to be able to tolerate, and you're going to have to stop the treatment. But you don't know if you're like in which of the thirds you are. And so try it and see and experiment with it. And then based on that, we'll do a treatment plan to support you with multidisciplinary approaches.
The,
It's worth noting that broadly speaking, we're seeing more attention to this idea of de-intensifying therapy. That the
Hmm.
sense, I mean, I had one of the oncologists who worked with me many years ago was, he just kept adding more stuff and said, four is good, six must be better. That's not true. Trying to figure, and this is a case where we started out with, 5 years, then we started adding 8 years, 10 years.
Yeah.
There's probably incremental benefit there, but there's also incremental lifestyle decrement. So I
Yeah.
think, one of the things that's really interesting when you go to the posters is people are actually saying, not how much can I give, but where do I start, backing off a little bit. And a lot of the times with clinical trials, we're trying to find maximal dose. Maybe we should
Hmm.
be thinking about what's the most tolerable dose that finds that right balance, or giving people tools like shared decision making to help figure out what that right dose is for them.
Yeah.
or even can they be adding on these CBT workshops during the course of treatment? I just based on our own personal experience, it was only clinical based options in the clinic. It was never anything that was supportive care necessarily, unless we went out and looked for it on our own. So maybe putting this alongside would be helpful for families.
Let's check the next one. Okay, next topic is movement. This was the big highlight of last year's ASCO with the challenge trial.
Yep.
There were still some really, really interesting studies this year that really back up that research done. So let's have a look at it. John, I feel I'm keep on calling you out, but this one was shared by you.
Yeah, so back in, I guess it was probably 2006 when I was running the oncology practice, we hired a lovely lady, Sammy Mansfield, to develop an activity program for our patients. And we didn't have anything fancy. She would go in at 5 o'clock and move all the chairs out of the way in the reception area and would have movement classes in each of our cancer centers. And we didn't get paid for it, but it was the right thing to do. And now the evidence continues to build to answer that question. And Challenge was a fantastic trial last year. I mean, the message was solid. People could, pick nits and see things aren't really, that they're confounders. But at the end of the day, I think there's a lot of evidence that making sure cancer survivors are moving. It doesn't mean you have to run a marathon. You can do some fairly simple stuff. I know on my iPhone, I get, chair Tai Chi and all sorts of crazy stuff because I've apparently reached a certain age. But the idea that it's just doing some minimal stuff is really important. And this is of all the posters about exercise and movement, this is the one I highlighted. 1 in 4 are meeting this standard. And actually, as you go down to that bar graph on the bottom, it shows by disease how few people are meeting this standard. And this is relatively simple stuff. Now, back in the day, we had YMCA and the Armstrong group,
Yeah, live
Livestrong,
strong.
had
Yeah.
some partnerships there. But you don't have to go to a gym for this. You can take a walk. You can do very simple movements inside your home. And it's great when people do want to go to the gym and they do want to run a marathon or they want to do CrossFit. But there's a lot of different ways to make this happen. And there's no doubt in my mind that certainly it improves the length of, but also the quality of survivorship. And that's a big chunk of the battle here, right? Is that even if there's uncertainty about, how long someone lives, there's uncertainty about how long I'm going to live. I certainly can live a better life if I incorporate this into my life.
Yeah, and obviously we're N of one, but Tracy was a 5X her prognosis, and she was a runner before she was diagnosed with cancer. She was running as soon as she finished radiation therapy, she was back out doing run walk until she was getting back to running. Even when she got to the point where her balance was off, she was still in the driveway walking around. So, I'm sure that her cardiovascular system was a great reason why she lived as long as she did with glioblastoma.
And something I'd like to share here too, I think this is like also massively culturally. Um, so I come from Portugal and I just find that like you just have to walk to places. You cannot drive to certain places. And I think when I'm in the US, I just walk so much less because cities are not built for walking. And I think that's one of the big challenges for patients because we're telling them you should walk more and like try to go to the grocery shopping and walk. That's just not feasible where most folks live. But again, start with little movements, go around the block, and that helps.
I,
We
I think
have,
more practices are doing this now, but it's far from universal. Uh,
yeah,
and it's and it is far from really being a guideline recommended, like this should be part of your care journey versus you can do it if you want.
yeah, yeah. We have here a few comments on the chat. Elle is asking you, John, was the movement class well attended?
Yeah, it was well attended. Now,
Sorry.
granted, we were seeing, thousands of patients every year. We didn't have the capacity for that. But the classes were full. But the interesting part was seeing the oncologists and the nurse practitioners, the folks providing care, seeing what was happening and using that, and also sending people on to like the YMCA program.
Yeah,
And we've seen more of these programs develop in the community as well. But you do have to stick with it. This is one of those things that's not reimbursed. So you have to decide that this is a value proposition for your role in the community that you're not just in the business of hooking up IVs and handing out a 30-day supply of pills, that you're in the business of lifestyle.
yeah, yeah. Prescribing physical activity. While you were talking about Tai Chi and Qigong, John, I'm gonna invite you to one of our Tai Chi classes. When I saw this study, I don't know if our Tai Chi instructor is in this call, Marie, but this is one of our best attended classes every couple of days. Tai Chi or Qigong. People just love it. I've tried it. I also thought it was not my thing. It is. And I just loved seeing this study because it's something that can be easily found for patients on YouTube, online, on the local gym. And here, looking at the data where we actually seeing improvements on cancer-related fatigue is just awesome. So highly recommend trying a Tai Chi class. John, Jason, I don't know if you've experienced with any of these like modalities or in practice or in your personal life.
I haven't, but I'm encouraged to see that it's older male cancer survivors the ones taking it up. So like that's an encouragement for myself. I know that Tracy's neuro-oncologist did a lot of integrative care webinars, um, and she did it out of her own time because it was not a reimbursable thing necessarily. So I think I think people want to do these things, but it's about time and creating monetary value that's typically the blocker on that. But yeah, this looks great.
I think it's a really good point about time and space. And boy, I've gotten out of focus suddenly. Let me cycle my camera here real quick. I'm
It's
better.
back.
Uh, we were able to do this in the practice settings by being really adaptive. And there are plenty of good-sized cancer centers out there who could do this. There are plenty of folks in rural settings who maybe don't have even practices that are open 5 days a week. So it's more challenging there. But I think that we're getting more used to using our phones as part of this toolkit. And I think that's an opportunity. I haven't seen anything that's been really cancer focused in terms of an exercise app, and maybe some of the folks on the call would be more familiar with that. But that seems to me to be an interesting opportunity there. And I probably could, give Sammy a yell, and she probably will yell at me for not knowing these things. But I'm sure there's that has got to be an opportunity that is a little bit more available. Jason, I just want to note your comment about time. There were a couple posters this year talking about the time burden of being a cancer patient or a caregiver for a cancer patient. And you do run out of time. And if it's this or preparing food for the family or this or making sure the prior authorization is approved and the drug is refilled, people unfortunately have to make some of these choices that sort of fit where they are in their journey.
Yeah. Well, I could tell you for the amount of time we sat waiting for labs to be called, they could have been running these sessions in the waiting rooms.
Yeah. And this one, again, similar yoga, different modality, but again, seeing good results in terms of like mood disturbance and insomnia. This is one of the other modalities that we do a lot in the After Cancer Online, that patients love and keep on coming. There was some like previous research, but I think here looking at the results of this 4 week program is very it's very exciting. And again, it's something that some of the centers that are looking at how to start their survivorship program, what is like 1 or 2 classes that I can do. These modalities are evidence-based, and this is a good place for you to start with, either online, either in the practice, either via a partnership. But definitely very excited when I saw this yoga trial.
Yeah, I would say that one of the great things about the abstracts at ASCO's annual meeting is they are real world data. There's a lot of times it's single institution, but it means that someone has figured this out. And if you attend the poster sessions, the poster writers are there. So you can ask questions about how did they do that? How do you make sure you get funded? All these sorts of things that are really important. I'm not a yoga person. I did it one time and I kept seeing everybody else's faces, so I knew I was doing it wrong. Um, but the idea that this is something, particularly as you're working through fatigue or working through neuropathy and balance issues, it is the just movement that doesn't require you to take on much other than even a mat or just a soft carpet.
And as I sit here as I don't know what I call myself, caregiver who's lost their loved one, like these are the things that I need to start moving on again and doing. Like I spent so many years, I mean, I probably spent 4 years not exercising, taking care of 5 kids, taking care of Tracy, and like these small little things are things I know I need to do. And I wonder if there's another audience that's being left out here potentially.
Yeah, there were a few studies on caregivers too, not only the burden but also mental health. Yeah, talking about mental health. So let's look at these studies. I think this is everyone knows there's an impact. Everyone talks about it. We know that anxiety, fear of recurrence, depression might come with a cancer diagnosis. Let's see what initiatives the abstracts are talking about. So this one was for young adults. I love seeing studies about young adults because they're not enough. And this specific one is just a different modality for emotional well-being. So we're talking about expressive writing, healing arts is definitely a field that is starting to appear a lot, and we're seeing like the big cancer centers having healing art classes. Again, this one is for writing, using it to help people go through this body image distress. Any comments?
I will tell you that this is something that when I do my work with the Young Survival Coalition, we have a summit in the spring and a wellness weekend in the fall. And a lot of what we do is this, because really, no matter where someone is in their journey, they can do some of these things. And I remember we were in Arizona last year, and we did Mandelas for folks. I will tell you one of the most amazing moments I've had as a board member. It was our first wellness weekend was in Florida a year ago, and we had someone come out and brought mermaid costumes. And these young women who were struggling with body image were suddenly put into this pool and this environment where they were made up like Ariel from Disney, and you could see them talking to their partners and saying, "Look at me." And I still get a little bit verklempt, just thinking about that moment that there's a bunch of different ways to solve for this, but to not address it is not solving for it, right? And it
Yeah.
doesn't make it go away. It doesn't make it necessarily better, but giving people tools to understand this sense of self-worth, the sense that I still have something here, or I can develop something it's a elemental part of the journey.
Yeah. Something I love about this one is low cost, home based, which means that it's accessible. And oftentimes behavioral health is not accessible. But also oftentimes, like not every patient will need to see a therapist on a one-to-one basis. There are other tools that can be done on a group basis that are easier sometimes to integrate. Again, there's no specific reimbursement. For group sessions, there actually is for behavioral health, but this is if you're working at a clinic who is trying to do something to support your patient's emotional well-being. Body image is huge, fear of recurrence, anxiety. There's so many topics that you could be doing. Little workshops like this one with a social worker, expressive writing, healing arts, support groups, and there's other formats. But this is a good place to start trying to support your patients if you don't have a behavioral health clinic next to you or inside of your hospital.
And to riff off of something Jason referred to earlier, when we had one of our nurses had a Mandela program in our infusion rooms, not just for the patients themselves, but for their caregivers,
Mhm.
and writing programs and things like that. So there is time, and that didn't require building a new building.
Yeah.
That just said, you know what, there's a time burden here, but there's also an opportunity that comes with it. Let's take advantage of the opportunity.
Again, in depression, closing the depression gap in community oncology, this is something that we've heard so much in this last year, I think, different outcomes from like patients in rural areas versus more like CDs. And again, we're seeing that mental health is also part of that. Um,
So I highlighted this and another one in some of the stuff I've been communicating, and this was first the idea that you can do this in community oncology, that it doesn't
mhm.
require an academic system to make this happen. The other thing I thought was interesting in this, and this was again small study, but showing that the patients from a rural setting actually did better from an overall survival standpoint than urban patients, which was sort of antithetical. They said that
Yeah.
wasn't what we expected. But there was a separate poster that looked at treatment of depression as a an independent uh, indicator of survival improvement. And so, like a lot of things in oncology, it's giving people a space to acknowledge that this is an issue and something they want to be addressed, and then making sure you have the tools to address it. And too often, what happens is patients don't want to, show any weakness because if they show weakness, am I going to get my therapy, reduced or discontinued? So I'm going to be strong. And on the other side, it's the care team who may not be really skilled in addressing depression.
Yeah.
And we see plenty of folks who do screening for distress or screenings because the COC says you have to do it, but that's not the important part. The important part is how do you address it? How do you give people tools to change these things? So what I took out of this was if you build it, you will have meaningful results for your patients. So figure that out. And when I ran our practice, we really did try to find counselors who were focused in this area rather than just saying, here's the yellow pages, find somebody. And that is tougher to do than ever right now. We have a shortage. We have a lot of need and not a lot of supply of folks in this business. So, in a lot of cases, I think from an oncology practitioner standpoint, we have to do some shopping for our patients to make sure they're finding people who can really address their unique set of needs.
Yeah, I found the screenings for depression typically happen with the medical associate that does like your vitals, and it's very like non-personable, just run through the script. So I think Tracy was just trying to get through it as fast as possible, regardless of what the questions might be.
Yeah.
Um, and then I think better ways to kind of undress this and get to understand what's going on is like asking about community, asking about the support systems, and then if you see gaps in that, there's ways to like, as John said, vetted resources versus here's a list of 300. Good luck.
Yeah. And just something on this specific study, they're talking about this collaborative care model. So if there's any practice administrators in the call and you're looking at how to set up your behavioral health program and support for your patients, this is a model where you can partner with other organizations and create this collaborative care model to provide behavioral health for your patients. So this is something that I would like to highlight for you to take home if this is one of the challenges you're trying to solve this year or next. Last but not least, technology. So let's go for this. This was an interesting one because it's talking about the channel, but it's also like a topic that it's often not talked about, right? So they're comparing digital app versus a print, and they're talking about supporting their patients with job retention. I mean, how many times have you talked with your patients about retaining their jobs? Like this is not common practice. So I kind of like liked the study because it's talking about something that it's not covered. And then I love everything that is digital versus print because that's part of the after cancer and what we're doing. Any comments?
So I would comment first on job retention. One of the things that we struggle with in survivorship is financial distress. And it's often not the cost of the treatment, it's the cost of losing a job or losing access to income. And there are other posters in that we're looking at. The lower your credit score, the less likely you're going to have a long and good survival. If you're unhoused, it was going to impact survival. So this idea that, making sure people have the tools to not only retain their job, but get any modifications that are needed I think are really important. We live in a time where people are making choices because they're single parents, or they're making treatment choices because they live in a multi-generational household. And I do a little bit, not a lot, but a little bit of volunteer work with Triage Cancer, and
I
this is
was
one
going
of
to
their
mention
focuses
them. Yeah.
is, making sure people have the opportunity to maintain the income and for better, well, not for better or worse, for worse, as we start seeing, sort of publicly available insurance options being tied to work, this is going to be even a more important issue. So that was all said, and I actually brought this back to our board at the Young Survival Coalition because we have largely gone from paper to digital, and just to say, listen, there's still value in that paper resource. And I'm an old guy, so I still use a lot of paper. And I was at a conference this last week, and I'm going to write something up about it, and all my notes are on paper. So I think,
Yeah.
not just doing digital because it feels good, but making sure, again, we're listening to our customers, our constituents, and doing what they need, not what's convenient for us.
Yeah, I mean, the digital is huge for me. Obviously, I lived and breathed in corporate world, but the minute we got home with our binder from the hospital that said "Welcome to brain cancer," I threw it in the garbage. One, because it was paper. Two, because I don't want a binder in our house that says "Welcome to brain cancer." And the reason I even built Ember was, from a user experience point of view. I don't know where the answer to my question exists in all these even like digitized PDFs and all these websites. So I created the AI companion so you could ask the question and get the answer and then help those families figure out the next question they didn't even know to ask.
Yeah.
So I can definitely see this being helpful. At Ember, we have 70% of our users come back and ask more questions later. So I think they also see it as something they can trust.
Yeah. So just one note in terms of resources for helping patients with job retention, advocating for themselves at work. Triage Cancer is a great website that you can, I think they have resources for clinicians, but also for patients.
Mhm.
And I would highly recommend if you're a social worker, financial assistant, getting questions like that, that's a great, great resource that you can have in your pocket. There's a lot of talk about digital navigation, a lot of startups, a lot of companies doing it. So I just had to include this one here um, of how we can help reach the right specialists and coordinate care. Any comment? I guess like Jason, this is your.
Yeah, I've talked to navigators all the time. So the data that we presented at ASCO from Ember was based on essentially a GBM navigator, and it showed that of the 3,000 users that we'd had, most of them are using the companion after 10 p.m. and before 9 a.m. So, most services are a 9 to 5 service. And oh, by the way, it's English first. And we saw people coming to the companion utilizing, non-English alphabets. We saw Arabic, we saw Hebrew. So the way I talk to navigation teams is like, one, it's Ember is, or these digital navigations are mobile, they're multilingual, and they're 24/7. And you probably can never achieve that with the human factor, but it can help those families get answers to those basic questions, whether it's terminology or, treatment options, and they can have a more sophisticated human interaction with navigators at that scheduled time, which then hopefully makes that engagement with the navigator human to human much more impactful and effective and cost effective as well.
Yeah, I will tell you that I know these folks, so I was really excited when their poster was there. And the digital toolkit is great. I think one of the challenges for people impacted by cancer, whether they're patients, whether they're caregivers, is sorting through all the stuff's out there and finding what works best for them. And I think it's challenging from a practice standpoint to say use this tool or that tool. What I always hear is just please not a portal. Um, this tool actually, I think, is great for a number of reasons. There's actually a back end of this tool that allows the community and academic physicians to do a better job of sharing patients, less logistically challenging than traditional mechanisms. So you're seeing a speed to, understanding what those academic center options might be, but also allowing people who have the academic center to go back to the community setting if that's more convenient for them as well, because they'll be able to get the same therapy in those settings. So there's a thing on the backside working particularly well here, but the idea that should you want to pursue a clinical trial, that we're reducing barriers there. Should you want to know about therapies only offered at tertiary centers, we can lower barriers to making that happen. We can't solve all the transportation barriers, we can't solve the economic barriers, but we can look at some of the logistic barriers and try to lower those as well. I think the other element of this from a survivorship standpoint, and I think Jason, you called this out earlier, and Mariana, we've had this discussion that survivorship isn't something that there's a line in the sand. If you're on maintenance therapy, and you are going to be on maintenance therapy for some time, you have issues that are survivorship issues. And so this idea that I can get information that can help me make decisions after hours, whether they're just cogitating things or should I go to the ER or not, or things like that, and having these consultations available. There are some really good folks out there doing great things that I think are game changers from when I was running a practice where from 5 o'clock at night till 8 in the morning you could find a doctor, but at 2 in the morning it was a little bit groggy. Having people who can do this, and really we're moving now into an era where we're starting to see, I think the first virtual cancer care clinic was certified by ASCO not too long ago. So the idea that for kids like my kids who do most of their healthcare engagement by their phone, I think you're going to see more of that, not just from the demand side, but the supply side as well.
Yeah, and I always say that we finally got everything we needed from a care perspective at hospice. I got someone I could call 24/7. I got the truth of what I needed to hear versus data and possibilities. And I got someone who would come to my house if there was a real emergency. And I think that's the kind of care we need to put at the beginning, middle, and end of the experience. And I think AI and digital can provide something that gets us closer to that.
Yeah. And something interesting to notice is that I love seeing more research on these tools and these navigation resources because when patients don't have this, they are on Google. They are on ChatGPT. They are looking for information online anyway. And so giving them a tool that you know it's evidence-based, that you know was built for this purpose, that has guardrails for this need for that patient, that's the best that we can do because we know that we cannot fight against technology and AI. It is going to come, and we just have to make it as safe as possible for patients because otherwise they're going to find other ways of getting that information online.
1,000,000%.
Again, this is a similar study. I think we're getting in the last few minutes of the session, but again, all personalized needs adapt follow-up care after breast cancer. This was a different model that was tested. And again, it was like nurse-led, which is something that we're starting to see in survivorship. EPP-led clinics, nurse-led clinics to support patients. And in this case, it's not only nurse-led, but it's also multidisciplinary. I don't know if you have any comments about this one.
I would just note that in the practice I ran, what's one of the things we had our APPs do was focus on sort of the quality of life issues. The oncologist focused on the treatment of the cancer, and the APPs would kind of worry about everything else, and built longer, appointments for them to really take time to address these. And we know that patients will tell nurses things they won't tell their doctors because the doctors got their hand on the spigot. So I think it's really important. I just co-authored an article with a couple of colleagues looking at the role of this dyad of the oncologist and the APP, and how do you sort of get the best out of that partnership you can. And it's not strictly a port and starboard, you see one, you see the other, but really allowing some of these folks to specialize maybe in genetic counseling or in survivorship or in
Yeah.
other areas, and really go deep in those areas to provide a deeper level of expertise and really a deeper level of time, I think, for patients to really explore what aren't easy decisions. And Jason, I'm sure you had many difficult decisions that couldn't be handled in a 7-minute visit. Creating those opportunities, I think, is really important if you're running a practice or a service line.
Yeah, and some of the feedback we see on our platform is people ask AI questions that they would never ask their doctor.
Yeah.
100%.
100%. So this APP-led model is something that we're seeing as a trend for hospitals setting up their survivorship clinics. They're going like KPP first. So I can really see how this is going to grow in the next few years for the follow-up care, where a patient is seeing physician assistant or a nurse for follow-up, and needs are escalated when there's something wrong to the oncologist, which gives more capacity to clinics for the from the oncology perspective. So this is definitely really interesting. This is the last one. Jason, I'm going to call you out on this one. You mentioned you attended this event, and there were a lot of insights that you wanted to share.
Sure, I know we're up against the clock, but it was fabulous to see an oncologist at University of Cincinnati, the head of R&D from Bristol Myers, the head of U.S. Oncology from AstraZeneca, the head of Texas Oncology, one of the VPs of Tempus AI. I'll talk about the use of AI in oncology. One of the main things was not to be fearful of utilizing it. And they were talking to they wanted to have more doctors use it, essentially, more oncologists. Um, and some of the pushback was it's not perfect yet. So one of the pushbacks to that is to what standard? Because they talk about, in digital pathology, for example, there's less than 7% consensus in like traditional ways of describing, what the diagnosis is. And with AI, you already get better outcomes. So I think the main thesis here is that it's a tool. It's not going anywhere. We need to start utilizing it. We need to not utilize it without human interpretation because it's not a replacement. It's a complement. It allows us to synthesize at scale. And I think that's some of the great things is you see, drug development, utilizing AI to find new target candidates and accelerating that in through preclinical. You see, Texas Oncology being a huge proponent of technology and again around improving patient care with access, like we talked about with digital platforms. So it was a really engaging session. It was probably the best one that I went to while I was at ASCO, and I think you should continue to watch the space.